Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter. Hello and welcome, everyone. My name is Renee Garrett, and I am your SpeechTherapyPD.com podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEUs. Here are the financial and non-financial disclosures. Our guest tonight is Nikita Pangarkar. She receives a small honorarium from SpeechTherapyPD.com to speak as an invited guest for this presentation, and she has no relevant non-financial relationships to disclose. I am a paid employee for a private consulting firm in the Commonwealth of Virginia. And as the host of this podcast and a guest or a presenter on other webinars for SpeechTherapyPD.com, I do receive financial reimbursement. I am the current secretary for the Communication Disorders Foundation of Virginia and a member of SIG2 Neurogenic Communication Disorders. Questions tonight will be answered at the end of the presentation, but you can place them in the chat box or the Q&A box throughout. Now, without further ado, I want to welcome Nikita Pangarkar, MA CCC-SLP, who is a cognitive speech therapist, business and wellness coach with 10 years of experience in healthcare and education. She currently provides specialized coaching and consulting services for professionals and students through her company, Thoughtful Coaching. As a background, Nikita has a Master of Arts in Communication Sciences and Disorders with a bilingual and multicultural certificate from the University of Texas at Austin and a Bachelor of Arts in both psychology and educational linguistics. She has offered services as a literacy specialist, community care personnel, speech-language pathologist, and counselor working in private, school, and nonprofit organizations over her career. Her specialty areas include cognition, counseling, neuroscience, bilingual education, academic language, and learning differences. She loves to find creative methods in order to support her clients and deeply enjoys collaborating with other specialists and SLPs in her community. Welcome, Nikita. So great to have you.
Thank you. I'm so happy to be here.
Yeah. So, just to kind of intro before we get into the questions, I have a question. So I'm looking through your bio and it's bilingual multicultural certificate. Do you mind sharing, are you bilingual?
I am. I'd like to say I used to be trilingual, but my Spanish, I have not been practicing it as much. So I am native speaker in Marathi, which is an Indian language, and then English, and then Spanish was my third language.
Okay, that's very cool. So I recently did a bilingual podcast. So that's why I asked, because I think it's really important for us to highlight especially when we're talking about what we're talking about tonight with sensitivities to immigrant care, to highlight, there's so many people in our field now who are multilingual or bilingual, and how that is impactful for your assessment and treatment practices, because it's just a great learning point for everybody.
Absolutely.
So let's just jump right in. So tonight, I'm just going to go back and read the title, because I think that's also important to talk about when we talk about culturally sensitive interventions, because this word culturally has been kind of, I don't want to say thrown around, that sounds terrible, but we started off with this culturally competent was the kind of an initial term, and it's really difficult. We've talked a lot about this in the field and a lot on the podcast about how it's really impossible to be culturally competent, because there's so many cultures that we're impactful and that our patients are experiencing. And so having this title of culturally sensitive intervention, I think is really just a great starting point, because we're looking at how we serve those people who are immigrants and the considerations that we need to have for quality care for this population. It's ever growing. And again, it's not just one cultural, right? We have so many different cultures that we serve. So I think that's just a really important point to start off with. But what would you say are some of the big considerations that you've witnessed in your work that's kind of really impactful for supporting people who may be immigrant clients?
Yeah, absolutely. So I will say, kind of going off of what you're sharing, it is true that there are so many different kinds of backgrounds represented in the US now, and it is growing. And I think that thinking about it as maybe not making assumptions based on what we kind of know about our own culture, and always being inquisitive and asking questions about things that we may not know or may be part of our culture that that could arguably be different for other people, is, I think, very important to just kind of have that framework as we are taking care of our clients. So that would be the first piece. The other piece is specifically in our field. We are so it's kind of interesting, because the diversity of the providers is not always equivalent to the diversity of our clients and the caseload that we are working with. So that is something that is a little bit tricky, because I don't know what the statistics are right now, but I do believe I think it's less than 10% of SLPs. I want to say it's 8% are non-white. So and there is that piece as well, and just having that thought process of being curious, I think, is very important. And so along those lines, I think the other piece is that what is equally important is for us to have a good kind of network of coworkers who do speak different languages and have, come from different cultures, as part of our team, or just as part of our network, so that we can ask questions if we need to, and we can do our research, especially when there are situations where we're like, well, this is kind of interesting, or, we do have an intuitive kind of understanding within ourselves, I think, as SLPs, that, oh, this could be something, or you have just this intuitive feeling that, this could be something that is cultural, or it might not be. It's always good to ask and have those coworkers that you can have these discussions with, so that we are providing, comprehensive care for our clients.
Yeah, no, I think that's great. And I think cognition and language evaluations and treatment are one aspect, but I know early on in my career, I ran into that with dysphagia patients who were, because I worked in inpatient rehab, and we were in I grew up, it's the same city that I grew up in. And we have a large seaport here. So we have a lot of people from a lot of different ethnicities and backgrounds and cultural experiences and race. And one of the things that we ran into was we were getting clients who were vegetarian from their culture, not because they decided for a health choice or whatever that they were going to be vegan or vegetarian or whatever. And this was a patient who had some pretty significant dysphagia as a result of a stroke. his diet was vegetarian based on his culture, and they kept sending him raw salads. And that was pretty much the extent of, at that point, because this was 15 years ago. So at that point, that was what the vegetarian diet was at the hospital. This was before
Sure.
IDDSI came on board. And I always stick with that one because that was the first, I think, real experience I had not as a student, but as a working professional, of trying to help
Mhm.
advocate and figure out for this patient what was culturally appropriate for him based on the diet that was recommended. And it was funny because his traditional vegetarian diet was probably way more in line with the dietary recommendations or the diet texture recommendations versus the raw salads that the kitchen was setting up
Right.
for this patient.
Yeah, that's fascinating. That is such a good, yeah, that's so interesting because I do work in a different space. So it's interesting to hear because it does show up in all areas of our work really in different ways.
Yeah.
Yeah.
I think that's definitely a challenge for those of us who work in the adult world. But, what are some of the challenges you've witnessed just in your work when you're supporting clients from different backgrounds and different cultures?
Yeah, so I typically, so I do work typically with pediatrics, and I do a lot of like speech and language pieces, and I will say, I try to be sensitive, and I am aware of a few different areas where we might want to spend a little bit more energy, kind of asking questions or investigating a little bit to get a good understanding. Of the differences with the language pieces, but some of the areas that I think are sometimes of challenge are, just figuring out the pragmatics pieces in different cultures, because that can be very, very different. So it's not necessarily that it's a challenge, but it's really, making sure that we understand that, dynamics look different in different cultures. How much we speak, how much we make eye contact, like some of these goals are very, perhaps Western centric. And so we want to be very careful about that side of things. So definitely pragmatics, just paying attention to, different gestures, behaviors, and other kinds of, and eye contact and other kinds of ways of interacting can be very different cross culturally. And so that would be an area that I think, that gets missed a lot. I see in working in just working more globally with other speech therapists and just talking about that. That's an area that I think sometimes I often see goals for that aren't necessarily appropriate. Same goes for speech. And I think ASHA has a really good, I think, phonemic inventories from different languages. So it is a good resource for kind of looking at maybe some of the differences that might be there. But there are sometimes speech goals where they're correcting like maybe English learning or English speaking that is not necessarily an impairment, like a speech impairment. It's just a difference in how sounds are, produced in different languages that are carrying over. So that is another piece that I think it's important to kind of look at, which I have seen as again being targeted as a goal that would not be, a clinical goal. And so those are some of the areas that I think have been a bit of a challenge. And then also just having resources for a lot of different languages. There aren't necessarily bilingual assessments for many languages. So it is a little tricky on the language side to assess from a normed testing standpoint. And we do have to rely on a lot more like informal methods or just kind of doing, questionnaires and figuring out, what needs are based on that. So I would say those are some of the big challenges to kind of make sure that we are both being supportive and assessing sensitively.
Yeah, it's funny that you say that because I know when I was a brand new clinician and we started getting materials that were translated into Spanish, I thought, oh my God, this is amazing. And then I learned later that it was the straight literal English to Spanish translation, which took into took no consideration for dialectical differences, for regional differences, for even religious or cultural differences amongst the same language. And so that was something that was very eye-opening, because here I am thinking, oh, I got you these worksheets and the walk, and they're in Spanish, and I'm so cool. And then I realized, in theory, right, it was a good practice in theory because we thought we had what we needed. But then as we, again, aren't culturally competent, we're culturally sensitive, and we're culturally more aware that we can learn that we do need to have these supplemental materials to look at the holistic patient, the whole involving the caregivers and the families as we're able to. And so, do you have questions that you tend to ask that you get more information, or that kind of help you provide a better service or more understanding? And I say that because for me, a lot of times what I'll say to the family or the caregiver, if they're there, is, we just met. I'm so glad you're here, because I don't know anything about your family member, loved one, neighbor, whatever it is, whatever care they're providing. And so sometimes I just kind of let them roll with whatever it is they want to tell me about this patient that's can, really, again, be clinically relevant and relevant to the shared decision goal making that we're about to do.
Yeah. So in terms of, so I have a set of ways that I kind of, that like areas that I look at. And then there are also, I will say, and I'm hoping, but I'm sure that there are other assessments for adults that may have these resources in the manual. But I do know the SELF-5 does have like quite a bit of information in the appendices for like cultural sensitivity and different kind of language and cultural differences. Of course, you can't use. So I will say, so kind of backing up. So we always have to, check in to see if our client is bilingual, first and foremost. And if they are, then we definitely want to use a standardized test that is standardized on both languages. But in a situation where maybe there is some influence or, some of that, it can be helpful to look at these appendices to kind of get a little bit of context. If English is the primary language, but there is influences of culture and other languages. So I will say, ideally, always we want to get the bilingual assessment. And then the other question that I do ask, or other questions I ask the parents, is I do like to look at language. The way that I kind of break it down is to look at the listening, speaking, writing, and reading in all the languages that are spoken at home. So even if kids are exposed but not necessarily speaking, speaking the language, they're still exposed and they still have vocabulary and constructs for that second language. So I always ask about like proficiency in all those areas. And then I also ask about the context where each language is used. And so, for example, a lot of kids will maybe use like more English-based language in school. And so their vocabulary in schools is more based on, English. So the academic language is based on English. But in the home, they might be speaking like, talking about kitchen, home, chores, all that kind of stuff might be in a different language. So they'll have more vocabulary for, that secondary language at home and for those pieces. And where it's also important is in the community and who they might be speaking to outside of school, and building those connections. They may be using their secondary language. So it's important to know, even to assess like bilingualism and like exposure to languages, it's important to know these different aspects when we're doing our assessment. So those are kinds of the questions that I ask to kind of get a better idea. And then of course I speak with if I do have a client who's like a Spanish English bilingual, I will speak to my Spanish colleagues, like my Spanish SLP colleagues, Spanish speaking SLP colleagues, to kind of ask a little bit more about certain aspects if I need to. So I definitely make sure to to check in on different things, and they check in with me on the Indian clients that they have, and some of the things that they see that they're like, this is like different than how I would do it, or how kids that other kids I see are doing things, and is this a cultural piece? So there's definitely that piece that I also rely on in order to kind of get a good assessment.
Yeah, and I think, it translates over to adults as well, because we have a responsibility to make sure that we are evaluating appropriately if English is not the primary language, but also if English is broken, right? So say this is a patient who will, kind of stick with Spanish. Spanish is their primary language, but this assessment is, again, translated straight from English to more academic Spanish. And so it's not truly, if it's the, for lack of better terms, we refer to it as the King Spanish, because it was based on Spain Spanish, not Puerto Rican Spanish or Cuban Spanish or South America or Mexico or whatever, the other, cultural Spanish speakers' native country is. And one of the things that we talked about on the podcast that I did a couple weeks ago was about native language and heritage language and the differences between the two. And so you touched on that with the, this person is using this type of language at home, but then in school, they're relying on these academic words in English and maybe don't have the same academic language, whether that's a child or an adult who may be attending college or graduate school. They don't have that academic language in their primary first language or second language if they're I'm losing my train, not monolingual, not bilingual, but maybe has even more, like you mentioned, trilingual or multiple languages if they're able to speak. And I think that's a really important point, because that it's not isolated to adults or children. That's across the board and across the continuum for ages for our profession. And I know that we are really mandated on, at least in the healthcare system, and I'm sure in your, the school-based settings as well, on using a translator. And there's been I've heard a lot of kind of crazy stories in the last 6 months or so about, I don't know if this was something that happened as a result of the pandemic, because I know early on, again, I started out in 2010 as a professional and, spent however many semesters doing clinical work in the field prior to being on my own. And it's just funny to me to think that, I've always been in healthcare, and we always had the accessibility of translators via some sort of computer-based or auditory-based, telephone-based system. And so to hear people now saying that sometimes they use the family, or sometimes they just use a coworker, and I'm like, that's not legal. So
Yeah.
it's sort of a tricky slope. And again, I don't know where this sort of came from, because I always, for 15 years now, have had access to, or 14 years, have had access to using some sort of translator service. Again, whether that was an effective dialectal speaker or not, we were sort of, we had to use that. So, one of the questions that came up when we chatted was, the appropriateness of a translator and how all of that sort of plays out.
Yeah. So, yes, you have to have a translator when you are, when you have a client whose first language is not English in the US. And Yeah, I do feel so it's interesting because you will have a lot of families who are very involved and want to like really help or really like do do a lot of that communicating and kind of that sharing of that space in that way to support and it's very sweet, of course, and it's very well meaning, and it's part of the process. I do feel so the issue with when we have a translator, the idea is that, we do, the things that we are conveying are being translated in the way that we are conveying them. Unfortunately, like if we do rely on, other family members or whoever, we don't actually know what is being shared in terms of, the treatment plan and just care in like whatever we are sharing about care, so we don't know that, and so that is a problem. We do need to have a translator, and it is tricky because I've also heard about some of these barriers, so it is tricky, but yeah, that is part of what we have to do ethically for our clients.
Yeah, one of the conversations we had recently was about how even some of the translators that we get on the computer-based side, where they have like the screen and the visual, the translators are don't maybe have the medical vocabulary to really tell, like if especially for me, like if I'm doing a swallow study or something along those lines that we're trying to explain, like I'm trying to give the most simplistic description of what I'm going to be doing, but if I'm not a speaker of that language, I have no way of really knowing if that's what's being said to the
Right.
patient or to the client. And so that's one of the barriers with the translators. And then I even had someone who was from a very remote region in Cambodia in Southeast Asia, and the translator that we had was like, I have no idea what they just said. That's not that's
Yes.
not my
Yeah.
dialect. And so
Yeah.
so there's just definitely barriers with, and not that the translators don't do a great job. I don't want to diminish their role in any way, shape,
Right.
or form. But what are some alternatives when we run into those kinds of issues? Because sometimes we don't even know that those are issues.
Yeah, that is a really tricky question. Yeah, there is um and that is yeah, that is really it's a really tough question. I've been fortunate where most of the situation, like either I've spoken the language or it's been a situation where I could get a translator, and on top of that, I think I somewhat had some proficiency with some of the languages that the translator was speaking, so I kind of had a sense of where it was going, but yeah, I would have to really think about that. It's tricky because we don't want to rely on family members to convey. Of course, we do want family members to be a resource, especially if they are supportive, to be a resource and like helping with kind of, keeping care, practicing at home, or like, keeping care kind of active at home in that way. And we have to kind of be creative in the moment of what is possible based on the specific circumstances that that are present at that time and what resources we have, and kind of plan accordingly. That's always a very tricky one because we do want clients to have access to their care, and so that language piece is there. That is an aspect of being able to provide that.
Yeah, I agree, and I think it's tough for us who maybe are not. I don't classify myself as bilingual. I know some Spanish, I know some French just because I took it in school, but it's not adequate. Again, I don't have the academic or the medical vocabulary. I have the greetings, and I can understand much more than what I can speak back. So that sort of never had the conversational training the way that would have been great, you know.
Yeah.
And so I think that's tricky for people who are using translators and then trying to figure out the alternatives, because I know at least in healthcare, the legalities that are involved require us to use their version of whatever product they've purchased, to utilize that. And you can request a live in-person translator, but one of the things that I know came up in the health system I worked for before was that I had a coda that I worked with who was from the Dominican Republic. She was a native like Spanish speaker prior to learning English when she moved to the States. And she had to take a test in order to be a medical translator for the health system. And she didn't pass the test because, again, her vocabulary was what she used at home. It was culturally appropriate. It was what she grew up speaking to her family and her elementary school years. But when it came to being able to translate medically and in that arena was just a completely different set of vocabulary. And it was just that always stuck with me as just so like
Yeah.
crazy. Like crazy. She's native speaker.
Yeah.
She's I don't know what she's talking about, but she couldn't get
Right.
qualified to be the medical translator for our health system because it was a different set of vocabulary. And I think that's just such an important point because even if you're like for you having a dialect of an Indian language and then also having some Spanish speaking background, it's interesting that, would you be proficient in your Indian language to be able to do that kind of translation piece? Just as a like an offshoot, because this wasn't a
Yeah.
question we talked about, but just
No,
interesting.
I love that. Yeah, no, I love that question. And I think it really highlights, I don't know for sure because I haven't necessarily done the official process, but I would guess not. I would guess I wouldn't be because my like proficiency is definitely more in conversational speech, like speak in like the family or just like the city kind of conversational speak, I guess. Like that's where I'm proficient. I don't know that I'm proficient medically or academically because I didn't go to school speaking this in school. I mean, I might be able to be fine. I just haven't been in that context, but I imagine I wouldn't be as proficient as maybe somebody who did go to school or did do speech pathology in India, for example. Like I think that they would have a different language and different even ways of speaking around things that would be at a different proficiency level. So that's a great question. And it really does highlight how bilingualism shows up differently as well. I will say in practice, so if I were to do therapy, so it's interesting because I'm just kind of thinking about your question more practically, like in terms of, in my clinic and just like talking to families. I think I would be able to talk to families and probably do therapy. But I do think that the medical translation piece of it, like to be a translator, you have to have kind of a different proficiency level in different areas. So it's kind of interesting because I could probably provide care, but I wouldn't be able to be a translator, which is kind of interesting. Yeah. Yeah.
Yeah, I think that's a great point because providing the care and because again, for us as professionals, we're providing these functional treatments. And so if you're a native speaker, or at least proficient in the language, I would imagine it would be easier to develop the treatment and deliver the treatment. But when it came to the education pieces regarding the diagnosis, maybe it would be a little bit more of a challenge. So I could see it being really two different things. And again, I think that really speaks back to this idea of cultural competence when people were using that term, because we can hope that we are responsive to cultures, sensitive to cultures, aware of cultures, but I don't know that we can truly reach this level of competence across the continuum because we are such now, a more wide-reaching world to have the opportunity to serve so many clients with so many different backgrounds. So I think that,
Right.
yeah, I think that kind of segues into the question about common areas of differences in our scope that we need to be paying attention to.
Yeah, and I might have touched on this a little bit, but just I would definitely say the different areas. the different areas that I have seen the most, I guess, difference, or the most areas where we want to kind of, be a little bit more critical about our own biases, I guess, to say, would be the pragmatics piece for sure. So definitely social language and kind of, paying attention to certain dynamics. The speech piece as well. So it's interesting because, English, there's American English, there's different dialects of English in the US, and then there's also English spoken in other places. And so the speech, even the speech so the speech piece, and then also some of the grammatical pieces are a little different, even though they're still English. And I think that's something to pay attention to as well. I can speak to, the Indian English piece just with my background. And I know I've heard, and this is, really problematic, as we all know, but, just thinking about good, like American English as being good English is obviously a problem. And that's something that I have kind of seen a lot of. So we want to be critical of the fact that, or of just that concept, and also thinking about like how other Englishes are, and like how they're structured. And if we do notice that, oh, this is a different way that the person is speaking, not to assume that it is a language learning thing, and to know that it is, possibly a different dialect of English. So things like that, just in terms of some differences that we might see. So yeah, I would say speech, the social pragmatic dynamic pieces, and then some of the grammatical pieces, sometimes like between different dialects of English as well. And yeah, and to your point with the kind of translating from some English worksheets into Spanish, like word for word. So so in terms of like how vocabulary shows up in different languages, there are certain high frequency words in certain languages, and they're different. They can't, like, if you translate them, they may be like lower frequency words in another language, for example. So just paying attention to that as well. Like if we are, when we are trying to, especially when we don't have bilingual assessments, just when we're trying to kind of think about, how much support a child might need, like where they are at in terms of their language skills. Like we do want to consider all these pieces, and same with adults. We do want to consider these pieces. And I think those are the top ones that I can think of that show up in terms of the areas of difference that, I think those are the top ones. So speech and pragmatics, and then of course some of the grammatical and dialectical pieces as well.
Yeah, no, I think that's good, because I even thinking about, our immigrant clients who come here, and maybe they have some English and maybe they don't. And, I've met and worked with people who they're first or second generation, and their parents never learned English, or they learned limited English so that they could work, or those kinds of things. And so I actually have a couple people that are good friends who are their parents were they immigrated here, and they decided they did not want their children to learn the native language that of the country that they came from, because they wanted them to assimilate and be American. And so now both one is someone who's half Vietnamese, and the other one is half Japanese, and they now are like, there's a little bit of embarrassment for them that they don't know the language, and that they get like where their parents were coming from, but they see it as a barrier when they're looking at their own culture and their heritage, and also their ability to speak with their family who came over later, or maybe are still located like my one friend and her family, she saw his family in Japan, and she can't communicate in Japanese with them, and it's almost like a shame kind of area for her. And so I think, when we think about our patients that way, whether it's they did learn the language, or they maybe their parents didn't learn English, and they're sort of in this balancing act. And now they've had this either medical event, or like in the case of a child or a teen who maybe has a language delay, they're sort of, if the regular everyday typically developing normal adult without a neurological deficit or processes going on, they're kind of like in limbo. You can imagine how that's impactful for the patients who do have a neurological deficit or a child who has a language impairment.
Yeah, and I think you're really speaking to a few just super important points that, I'm just resonating with just the the pressure to assimilate in the US is definitely something that, we want to be sensitive about and I can even speak from personal experience. I mean, I've always been very strong about my own culture and just very proud about it. But I did notice, and I was one of those, and I know this is a shared experience, but I was definitely one of those kids when I had moved to the US where and even back, I would say so I was fortunate in that I was exposed to a lot of different languages because I moved around the world. Growing up. But I remember when I had come to the US, when, I was one of those people who was, kind of told that, I can't, they couldn't understand me if my stressors were not on the same, words or on the same parts of the words as was expected with American English. So that was definitely I was not understood, even though I was fluent in English. And I would definitely get a lot of that. Of course, my accent kind of changed as I was living here for longer because I was, exposed more to. And now it's funny because I have two accents. I have my Indian, English accent, then I have my American English accent. So I kind of code switch that way. And so that does happen for a lot of people. But I did feel the pressure of having to change my accent in order to be understood here because there wasn't that much flexibility and the pressure of that, and even in the schools and even in fitting in and all of that. So that is a very real thing that a lot of people have to face when they come here. And it is important for us as providers to be sensitive to the fact that, that might be what our clients are facing outside of, in the world when they're in the world outside of our clinical space together. And so, yeah, so just kind of thinking about that power dynamic and thinking about, how we can kind of create a safe space for them as well is important. So yeah, I love that you touched on that because that is such a big piece to the experience.
Yeah, and it's kind of funny to me because when I went to apply for graduate school, I I mean I'm from the US, so I speak English. That's my native language, but I have what's considered a pretty regional accent, and it's blended because my family is from two different areas, and I grew up in a different area from where my family was from. So I sort of have this blended accent. And when I went to apply to speech school, we had to do a speech and hearing screening. And the expectation was that we would hear better and speak better than the average people. And so at one point, I thought I was going to have to go to remediation for my speech because of the nature of my coastal / Eastern North Carolina accent. And it was so weird to me because this is my second career. So I wasn't early 20s, I was mid 30s. And so it was like, what do you mean I talk weird? And so I never, I don't know. I've thought about it before. And, but for this, it resonates kind of with me too, because it was like, it's almost embarrassing. Like, you're like, what's wrong with me? What did I do wrong? And you're not doing anything wrong. And that's the point, is that in order for us to be sensitive to, other languages and things like that, we have to appreciate that the interpretation of like you said, social pragmatics, but also the speech patterns, the intonation, the prosody may be a little bit different based on what your primary language is versus having English as a second, third, fourth language, however it falls. And if you're not, then I think, again, we have a lot of responsibility and education that we need to be doing on the backside for ourselves so that we can be more understanding and not identify that as a deficit.
Absolutely. Yeah, it is a balance of, questioning our own assumptions, and our own kind of ways of doing things, and making sure that we are, thinking about that when we are supporting our clients, doing our own research, and, which involves, maybe our own research work, but also talking to others who, do speak that language again, or have that, cultural background. Sometimes it's not even finding the most like if somebody is from a specific part of India or a specific, it can be even finding people who have some level of, like have some background in that general region can also be helpful. It's not perfect or ideal, but at least you get a little bit of insight, because it's hard to sometimes find, and I recognize that the specific, the same specific area of India, or this, or even India, or just, just any kind of like, or specific city or whatever it is challenging. So even having somebody who is, South Asian can sometimes be helpful, because there is some level of understanding that could be there that we can learn from. To help inform us in terms of supporting our clients, whatever that region or place may be, but just kind of having that that conversation with and it doesn't also have to just be speech therapists. It could be other medical professionals. It could be other people that we know. So just to kind of be creative in terms of how we can support our clients.
Yeah, it's funny. I'm sort of thinking through, like, in my mind of like the different medical professionals that I worked with, and I had a doctor that I worked with, I had several doctors I worked with who were Indian. But this particular doctor grew up in Maryland. And so, I had a colleague who was like, I think he grew up she kept saying, I think he grew up outside of India because his English is so good. And I'm thinking, oh my God, please stop saying that. Stop saying that. And so she went up to him one weekend and said, hey, where did you come from? She didn't even say, where did you grow up? She said, where did you come from? And he was like, Maryland. Like, Maryland. And she's like, no, but really, where did you come from? And he's like, Maryland. And she's like, but really? And he's like, but really, Maryland. And I thought that was like the funniest thing, because he's really legit he had zero native dialectal, like, how sometimes you meet people that are from maybe southern states that are like Texas, for example, or maybe a northern state where you expect sort of a dialectal inference or accent, that you would expect that you start hearing them talk and you would hear something like that. But he had zero accent. I have a friend down in Texas. I have a couple of friends down in Texas who, same thing, they talk and they really have zero identifiable regional accent. And it's always interesting to me, because everybody's like, are you really from Texas? And it's like, why would you ask that question? Like, where does this come from? Just appreciate the knowledge that they're sharing with you, and don't ask these questions that make zero sense and have zero relevance. Because I think it goes back to what you were saying about code switching, and you're going to have a different, like, my husband calls this the podcast voice, which is funny because I still have an accent. But when I speak with my family, I sound differently than I do when I'm speaking with my patients, than I do when I'm speaking with my students, than I do when I'm on the podcast. And so I think we all sort of have sort of that professional voice, and professional monitoring that we do of how we communicate, because we are the communication experts. And so I think when we're thinking about those considerations, are there other things that we need to be mindful of, and sort of keeping in the forefront when we're dealing with patients of a different background, and who may be immigrants and their families?
Let me think I feel like we were very comprehensive in terms of all the different, I mean, there's always more, but in terms of all the things that I've been thinking in this moment as being very, very important to consider. I think mostly just, just being sensitive, just being inquisitive and sensitive to needs. I guess the other piece that I was thinking about as, as part of part of just creating a safe space for our clients. So we definitely want to, if we can have, clinicians who are of the same background as the client, that always creates some level of safety. And I do believe there's quite a bit of research to support that patient outcomes are better when there is that kind of cultural background similarity between the patient and the provider. So that is something that we do want to consider. Sometimes if we don't have and we might not have like the SLPs from the same exact place as our client, but just kind of having a little bit of, seeing if we can kind of make that happen, or even other, sometimes there's other OTs or other practitioners who maybe can, greet the client or just kind of, create some of that safe space, who might be of the same background. I mean, who can create that, kind of safe space for them. I think that's really important. Sometimes also in some cultures, having a clinician who is the same gender is sometimes very helpful. And it's actually very anxiety provoking if it's not the case. So we do want to think about that as well. Especially when we're thinking about doing, like oral mech or like some of those a little bit more invasive kinds of procedures. I think that's a really important consideration to just ask, or just make sure, have that consent. And yeah, and some families, I think, prefer to kind of come together into the appointment room and just kind of being kind of thoughtful about that. Some people like to, just independently, or just have their spouse come with them, things like that. Just making sure basically that the client is comfortable in the setup while they're, receiving treatment, or just being educated on different aspects of their care. I don't think there isn't anything else that's coming to me in terms of additional things. I'm sure there's more that we could talk about, but these are kind of the main areas that I've seen as being important and that stand out in the work that I've done in the past few years.
Well, and I think I'm thinking, for me, like social determinants of health for me is always a big thing based on where I grew up, and then the population that I've served, because I worked in two different health systems, and I worked in sort of two different kind of unique environments, as far as like I started out in inpatient rehab, and then I went to acute care. And when I was in acute care, when I first started, I floated. So I was in a level 1 trauma hospital. I was in a level 2 trauma hospital, and then I was sort of in everything in between, and then also the country rural hospital, where I sort of landed, that now is no longer really the country rural hospital because it's really grown in that area. And so looking at just our general population, but when you're thinking about clients of different cultural and language backgrounds, different race, different religions, thinking about literacy and access to care, and maybe experiences they've had with care that were not necessarily a positive experience.
Yes.
So do you have any kind of advice, or just even like client stories would be, I think, really helpful for that?
Yeah, I think this goes back to just the creating comfort piece. So we really want to be sensitive. And I know it's within our scope as well to counsel. And I know that's not necessarily something that we get the most training on, but I do think that having like trauma-informed care, and just, making sure that we are kind of keeping tabs on our own training and understanding of that, I think is very important. Because the other piece that kind of came up for me as you were sharing that, is I'm thinking like a lot of experiences outside of the US can look very different than how it is in the US in many different ways, politically, socially, just stability wise. There's a lot of there's just a lot of like trauma that is that can be present. And both from just my personal experience, and then also just just knowing kind of like, just working with clients and knowing the areas that needed to be supported. I think that's very important for us to do as practitioners, and be aware of that. It's it can be a very different experience than what we know of here, we're used to, or what our experiences are. And so, yeah, so that is one of the pieces. And then in terms of yeah, now that could you ask your question again? Because I kind of went onto this train and then I kind of missed if there was another piece that might be worth kind of answering.
No, I was talking about literacy, and I'm glad you brought up trauma informed care, because I did a presentation on that at ASHA, and it was I had a lot of good feedback, and a lot of people were saying, they never thought of it in those ways, but a lot of people are not trained in trauma informed care. And you mentioned counseling, and I think it's definitely within our scope, and it's definitely an area that it's very important for us to seek out that information, because that, again, trauma informed care, that doesn't matter how old you are. That's across the lifespan. So it can be very impactful from, in the US, but it can be very impactful from, again, different cultural backgrounds within the patients that we treat across the lifespan and across the disorder. And I think that's just an area for so much growth for us as clinicians, and
Right.
realizing that health literacy is a big deal. Your background of being what your personal experience was with a healthcare provider could have been positive or negative, and how that impacts you throughout your lifespan. And then also food insecurity, because a lot of people will say, oh, that's not that big of a deal, but it is a big deal, and it is real, and it is very prevalent in the US. Whether people want to acknowledge it or not, it is a big deal.
Yeah.
And again, I think that those are sort of those things for me that are reasons that I wanted to do talks like this, because people sort of tend to isolate themselves into silos and think that it's this group or it's that group or but it's really not. We all have sort of this overarching connection across cultures, and it is very impactful for how we treat our patients, and the education and the things that we're able to provide to them from a treatment standpoint.
Absolutely. Yeah.
So it looks like we do have some questions. So I'll go back to the Q&A kind of early on. Someone said, I have an EI, so early intervention, nearly
Sure.
nonverbal kid. English is primary with exposure to 4 languages between home and school. It says French in parentheses. Isn't pushing 4 languages on a nonverbal too much to process, or do we have to accept parents' need to be culturally diverse?
Yeah, so we do want to appreciate parents, needs and want to have this culturally diverse experience. I'm curious about, English is the primary language. So are the 4 languages is it more like the parents want their child to be exposed to it, or is it part of their culture? I guess I'm curious about that.
So whoever asked that, if you could just kind of type that in the Q&A or the chat.
And I'm happy to answer both if it's hard to kind of have them back and forth. But yeah, I think if it is part of the cultural experience, then it's definitely, I would say, important to have that as a consideration. However, it's hard to answer without having kind of the details of, all the pieces, but I do think that it is important to take that piece into consideration as we are developing language, because that is what they will be exposed to as well in their home life, if it is part of their culture, and that is kind of the the inputs that they'll be receiving and kind of what they will be needing to express at times. So that is an important piece, but at the core, the language pieces have to develop. So if English is the primary language, I would still, and if the clinician is English, is only in. Was there an answer to the question? Oh, I thought maybe there was. But yeah, so if English is the primary language and you're treating English as a result, I do think that, kind of building those language skills is important with consideration to the parent's request, if that makes sense. So we still want to build the language skills, but we do want to be sensitive about that piece as well.
Yeah, it says one parent is foreign, school is another foreign language, one caretaker a fourth language.
Okay, so caretaker is one of the languages, one foreign language. Okay, and then parent as well.
So the parent, one parent speaks one language, school is in another language, and the nanny speaks a fourth language.
Oh wow. Okay.
And this isn't my area of expertise as far as a nonverbal kid, but I imagine that having exposure to language isn't going to necessarily be a bad thing. But I think I'm thinking about my patients that I work with who have profound intellectual disabilities. The language exposure isn't bad. It's consistency that can be problematic for like for any age group who has a language impairment or deficit, because the consistency sort of is the thing that helps them communicate, whether it's nonverbal or verbally.
Right.
It helps them communicate more effectively and be more confident in their ability.
Right. Yeah. And that's the tricky thing. So I always think about like treating in the primary language and then being kind of sensitive to the other languages or the needs of the parent. Especially if that is a language. So especially if parents speak a different language, and there are cultural components to communicating in social engagement. So we want to keep that in mind. I would say it maybe that way, is like treating in the primary language and then keeping in mind these other pieces.
I agree. Well, and I think at this point, we're sort of over our time, and so we can wrap up, because the other was just comments about American dialect and training of SLPs, and that triggers me. No, I'm kidding. It doesn't trigger me. It's just, it was interesting to read the comment about how attitudes about dialects and accents and what the gold standard is really needs to improve, and I think that's a really valid point. So thank you so much, Nikita, for joining us. It was just I felt like it was a really productive conversation and really reiterated a lot of points that were important and needed to kind of be made into the forefront about how we need to be mindful of other people and their cultural backgrounds, and also how we as clinicians can educate ourselves so that we provide this more patient-centric experience versus having that sort of closed-minded, one tunnel vision type of care. So
absolutely.
I just appreciate you being willing to come on tonight and do this, and hopefully we'll be able to chat some more in the future. Thank you, and we look forward to seeing you again soon.
Thank you so much.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Thank you for joining us at today's podcast. Remember to go to speechtherapypd.com to learn more about earning ASHA CEUs. We appreciate your positive reviews and support, and would love for you to write a quick review and subscribe.